that the upper maxilla resorbs faster than the lower jaw a lot of times. But is this always the case? It's not always the case, but this is what studies have shown, that this happens. Once again, this is the way how the upper maxilla, the way how it resorbs upwards and inward, and the lower, and then the posterior maxilla, same thing, is upwards and inwards, the way how it resorbs, the bone resorbs with time. And then the mandible, it's more of a downward and outward kind of in the shape, as the way how it resorbs there. So like in the posterior mandible, when they've been missing like 18, 19, or 30, 31 for a long time, they usually have a pretty wide ridge because the top has resorbed and then it comes down, because it, like this part kind of comes like this, more like this, and it starts to widen basically. But the problem is the nerve gets in the way, even though they don't have enough, like if they lose a lot of bone. So even though they have, so this is a classic shape of the way how, you know, when you lose teeth there, and bone with time. So what do you do? I mean, if you don't have enough bone, right? What do you do? I mean, so this is where bone grafting, augmentation procedures, like we talked about sinus augmentation earlier just a little bit, but just, you know, all kinds of different types of, there's so many different variations of augmentation. There's like the ridge split, there's GBR, guided bone regeneration, there's, you know, all different alternatives. And they even have like mini implants these days, right? And I talked a little bit about mini implants, but you have mini implants, and there are cases where mini implants are very useful. I mean, I talked a little bit about my grandfather earlier, and it's short time frame, I didn't have time, and one of the benefits, I can immediately load, and he goes home, and if something fails, we can take one out, put another one next door, or whatever. It's not a big deal, right? Unfortunately, nothing has failed on him, actually. It stayed the whole time, that whatever. But I'm just saying, people are like, oh, I don't want to do minis, whatever. I mean, but I think there's a place and a time for it, you know? And there was like a case where I did a full arch case, and I needed to stabilize her dentures, or whatever, because, you know, until they healed. So I placed like 4 or 5 mini implants, and just put them and had her wear her dentures, and she was happy for the time being until her regular implants healed. So there is a time in, you know, where it's called for. So I wouldn't. So this is where I say use the tools to our advantage. You know, it's like there. So use it to your advantage for the patients. You know. So once again, like, you know, socket preservation. So key to good surgery, key to being a good implantologist, I would say, is being a good surgeon is number one, like it all incision, you know, everything starts with an incision, right? Making good cuts, making good closures, and then being able to take out teeth well is very, very important. As I said earlier, I have like 3 practices. I have multiple associates. I even have you know, not everybody can take out teeth. People say they can take out teeth, but not everybody can take out teeth. And when I say take out teeth, I mean atraumatically take out teeth, because you want to preserve the bone. You don't want to, if I cut the whole buccal plate off and take whatever, you know, anybody can take out teeth. You know, that's something that you can do. But knowing how to take out teeth with preserving everything is a different story. And being good at it and efficient and fast is where you got to work on your clinical skills. And I can't teach you all that in one setting, or I can't, you know, explain all that in one visit basically. But knowing how to cleanly take out teeth, knowing how to, you know, close the patient up properly, those are very key factors to doing good, like, you know, leading to success basically down the road. What question do you have? No? Okay. So I mean, just basic socket preservation, basically bone graft. You know, you take a tooth out, we pack bone in there, and this is like a membrane that they place on top, and you suture, a figure-8 suture back there basically. But so it requires extractions, you know, and then you have like the GBR, guided bone regenerations. You have bone block grafts or whatever. Like GBR has a bit of a clinical track record now. You know, it's a newer technique basically. It hasn't been out that long, but it has a pretty decent clinical track record, and it works. It works very well. And so knowing how to do good bone guided regeneration is important for success, because if they don't have it, you have to build it up. You have to know how to build it up so that you can place your implants basically. And even if, like, you know, like you're placing the implant, the bone's damaged or whatever, then we do GBR in conjunction with the implant to build the bone back up at the same time. So once again, guided bone with titanium mesh, the titanium membrane and stuff. And this is how you build up bone, basically. This is the way how we build up bone. If they don't have it, you want to build the bone back up. And then there's like the block graft, the sponge bone graft, or there's lots of different blocks. Or you can even take it off the ramus or whatever, and so you can, or even here in the anterior mandible or whatever. So there's different areas or locations where you can take the bone. Yeah, and then there's ridge split. Ridge split is great if you have a big wide ridge or whatever, I mean big long spanning ridge. So never do ridge split on a single tooth location, because it's very difficult. It's actually very difficult. The narrower, the smaller it is, the location. Like if you're doing a single tooth extraction site and you're trying to do a ridge split, that's very difficult because you're going to break the buccal plate. If the buccal plate breaks, and you're trying to do a ridge split, you're pretty much done. You have to flip over to a GBR, and you have to hope that that bone is stable enough that you don't lose it basically. But anyway, so if you have a longer spanning area like this, ridge split is one of the benefits of it is it heals very fast. Like if you do this ridge split, 3 months later you can restore this case. That's how fast they heal. So I mean, it's technique sensitive. It's very technique sensitive. But if you know how to do it, it works very, very well. So you split the ridge. We put the implants in. The implants actually acts as an expander during the time. So the bone gets expanded. We fill it with bone, and then you place a membrane on top, and then we close them up basically, right? And then they heal beautifully. The bridge it widens right away basically. The vascularity. That's where it comes in. The cortical bone and the cancellous bone just kind of starts to, the vascularity starts to fill back in, and then it forms bone basically. So it's a very quick procedure to try and gain bone basically, but it's very technique sensitive. It is very technique. You break the buccal plate, it's done basically. So you have to be very careful, gentle, and you have to know what you're doing in essence. But it's a way to gain bone and quickly. So. But unfortunately, there's some morbidity because you have to do a big flap. You have to do all this. You have to have a piezo unit to be able to cut, or you have to use these drills or whatever. But so there's some technique. It requires more training basically. But it's there. It's there. Okay. And then obviously the sinus we talked about a little bit. Sinus augmentations. This is how we add more bone to the posterior maxilla. So ridge split is mostly in the lower jaw, but you can do it in the upper jaw, like upper anterior areas too, where we do ridge splits too. But in the sinus, we do either lateral window technique or the Cresto technique to expand or lift the membrane and then add more bone basically. So the Cresto technique is obviously less traumatic because you don't have to lay a big flap. And I do some of my cases like with the tissue punch. I go in, create the osteotomy with the casket, whatever, and then I do my sinus lift, and then I pack the bone, and I place my implant. So the patient, they leave, and then I place the healing abutment because I get good stability to the implant, and then so they go home with no suturing, and there's very minimal pain. And so the patients are very happy. So if you guys can try to deliver cases or do cases without minimize your trauma, right? The patients are happy, and if you can do that to your patients, you have more patients that are returning back to you to get more implants done if they need another one down the future. If you cut them open big and you hurt them, they usually don't want to get another one done basically because it was a traumatic experience, So you talk about patients will come into you and they'll be like, oh, I had this wisdom tooth extraction and the dentist was on my chest, like trying to take this tooth out, whatever. And so and then they get all afraid and they're like, I don't want anybody to take out my teeth anymore or something like that, So if you can deliver cases more atraumatically, that's better, right? Or if you can do cases more atraumatically, it's better. And so use the techniques that we have today. I mean, the tools and the techniques is all available. You just have to learn how to use them. And of course, yeah, it takes time to get to that level, but it's available. So once again, like single tooth extraction, bone graft, if you have bone damage, we can still build that back up. There's ways, and these, there's lots of ways to do stuff. I mean. So for us, for the beginners, I guess that are out there, you have to start somewhere, right? So where do you